What did you?
Welcome everybody and happy TNL. We are here today with Dr. Paige Prather. She was about to say something. I'm going to let her finish. But I'm going to go ahead and introduce our speaker to you guys. Thanks for everybody who's over here live. That means that you're an Airway Circle member. We could not do what we do without your support. So thank you so much. And we just celebrated our 4 years in September. So super exciting. Actually, at the end of this month, I'm going to do another really big special for membership. So stay on the lookout. Here we go. Presenting Dr. Paige Prather. Originally, am I saying your last name right?
You are. Yep.
Okay, good. Originally from Cincinnati, Dr. Paige Prather earned her dental degree from the from the Ohio State University College of Dentistry and completed a residency at the Dayton Veterans Hospital. With advanced training in oral ties, airway health, and functional appliances, she provides comprehensive care for patients of all ages. Dr. Prather has a special passion for helping anxious patients feel comfortable and confident about their dental visits. Outside the office, Dr. Prather and her husband, Matthew, stay busy with their 2 sons, Jaxson and Samson, and their dogs, Ada and Loki. In her free time, she enjoys running, rollerblading, attending car shows, and discovering new restaurants and wines. You're my kind of girl. The topic today is overview and expansion appliances and specific applications. Thank you so much for being here. First, let us know a little bit of how you're doing. You were one of our early speakers of Airway Circle. You were here a long time ago. So what has changed since you were here last?
Oh, it's actually a pretty easy question for me to answer, ironically, because I went back to my presentation from what I did last time, and I was like, oh my gosh, I'm just going to add to this and expand on it. So I would say I have kind of gotten just additional experience in the appliances that I talked about before. I've gotten additional experience in some TMJ appliances as well. And back then, I think I was maybe just starting with Vivos cases. And so I've gotten a lot more kind of like experience with those and seen some adult cases, which was fun because mostly last time I talked about kids. So I have some adult cases that I'm really excited about and we'll share a little bit about today.
Yay, awesome. Well, the stage is yours. You're welcome to share your screen.
Great.
And don't forget to let us know at the end how can patients find you and other professionals to collaborate with you.
Sure. So let me make sure that I do this correctly.
And as you're sharing your screen, I do want to let everybody know October 9th. Oh my gosh, I'm not going to remember now. Who do we have October 9th? Oh, I know. We have Dr. Mohammed from Canada. He's a myofunctional therapist, has an incredible book. So he's next week also live on Thursday. Oh my gosh, most of you are going to be watching this as a recorded session. So it's going to be old news because this is not playing until January 22nd. So happy new year. If you were here on a Thursday night. Here we go.
All right. So let me know if you can see my screen.
Yes.
Okay. Are you able to see the PowerPoint window?
Yes.
Okay, great. So this is the tensegrity concept. I spoke about this a little bit last time, and it makes a lot of sense when we're looking at the skull and what we're doing with expansion. So we're not just having an effect on the teeth. Orthodontics for years, that's been our focus, is moving teeth, into a different position. And of course, there's the cephalometric tracing, and we take some of that into consideration. But we have this tensegrity concept that really ties in the cranium and the sutures. And I think it's really important when we're doing expansion that you keep in mind that when we're having an effect in one area, that's creating an equal and sometimes opposite reaction in another area. And so as we look at our cranium, we have all of these sutures that hopefully can still flex and move. Some people do have some cranial strains and some areas that are locked in, which is why we take a team approach to our expansion and things, because we want, all of those areas to be flexible and to be changing as well. So as we expand, and what I experienced with my own kids is, you may get some people that develop headaches. You may get some people that, kids that react more strongly than others because they may have a little more sensory, um, stimulation and issues. So I actually have done training in all the different appliances and all the different types of expansion. I have a lot of tools in my toolbox, and I just sort of figured out what works better in my hands in certain situations than in others. Probably every single appliance my children have themselves worn. So I would say, I also have that personal experience as a parent to kind of understand, how complex it can be to get a child to comply. For adults, I'm actually, as you might be able to tell how I'm talking, I'm actually in treatment right now. I'm going to be expanding as well. And so I'll have that personal experience too, of how complex it can be when you're wearing an appliance and trying to function on a day-to-day basis. Um, but, I think the main concept for the expansion is just understanding we have all of these other things that happen as we expand. So this was an article I actually shared the last time that I spoke about the cranial strains and how they can lead to and or be correlated to the malocclusions. And it just further illustrates, how those sutures and their flexibility can tie back to the oral anatomy and the bite and the occlusion and things like that. So there are all these different expansion devices. And every single one of them, I think, has some advantages, has some disadvantages. There are more than this. Of course, we have the IGA and some others out there that are, similar in some concepts, but slightly different in design. And so these are the ones I was primarily going to focus on today and cover today as far as, what application might be good for these, what limitations they have, what advantages they have. These are all appliances that I've used in my practice and currently, still use most of them. I find, there is more than just the factor of which appliance that you're using. It's how all of this oral musculature is working in combination with the appliance. So that's another major factor I think we need to consider and have the right team together. We need people like Renata who are, working on our oral motor function, who are helping these patients develop, myofunctional habits that are reinforcing what we're trying to accomplish for the airway and for the development pattern. So I've found in any case, no matter what appliance that I'm using, if this oral musculature is malfunctioning, if it's doing, its bad habits still, it is going to slow treatment. It is going to make it unstable. It is going to make it really, really hard to make progress. So I think that's a key important factor. And I do have some patients that, life's busy. I get it. I'm a parent and a working mom and a practice owner. And it's hard to really stay on track with stuff sometimes. And so I'll just have an honest conversation if I have parents that are just not willing to, really factor this in and see myofunctional therapy or work on some of the oral patterns. And I just kind of let them know, we may not be able to reach our end goal. We may have to chronically wear some kind of retention, or, we may need to just stop altogether because we're not going to make any further progress with where we're at until you do this next step. So I think that's a key factor no matter what appliance you use. To me, the MyoBrace, the Healthy Start, the Vivos Guide, these are all fairly similar in their advantages and disadvantages. As kids, I tried to get my kids to wear the Myo braces unsuccessfully. That was tough for us. We really struggled with, coordinating our swallow and those kind of things. And it does take some commitment to really get them to keep trying and practicing and getting them to wear the appliance. So in all of these, I would say, one advantage for them is you can work with kids that don't need an impression. Now, Healthy Start is, not quite exactly the case for that, but with the Vivos Guide and with the Myo Brace, you can take a measurement or kind of estimate the size and use that, without having to get an impression on a younger child. They can do virtual check-ins. I actually have a Memphis location where I do MyoBrace with a MyoBrace certified educator. So I'm able to oversee that treatment without having to be there in person some of the time. That's a little bit nicer for families who don't have an option in their area or who travel really far, which we have a lot of those. Hygiene's easy. You take it out, you clean. There's really no, issue when it comes to hygiene. It is a little bit less costly treatment sometimes because we're not working with a lab to fabricate it. I will say the Vivos guides are really pricey compared to the Myo braces. So in that case, that's not necessarily true. I actually did a Vivos guide for my oldest, and it was really frustrating when he struggled a little bit to wear it, but it was less bulky than the Myo brace, and he did better with that. The positive muscular reinforcement is great. I actually use these sometimes for when we finish treatment. I actually use them as kind of like retainers and positive reminders of how we should be using our muscles, how we should be swallowing, where should our tongue be, nasal breathing reinforcement. I find them really helpful to use just to keep fresh in their mind and in their muscles what they're supposed to be doing with those muscles. It does help more with deep bites. If I have patients that I've done expansion on and they still have a lingering deep bite, then I will use it to correct the deep bite sometimes. And it can be used in younger patients. We have really, really little ones. When you go to MyoMunchie, you can use it in even 2-year-olds, but we have 3 and 4-year-olds in treatment with this. So Renata and I were talking about that just a little bit before we started. We want to get in there as early as possible. The sooner that we start, the more impact we have on growth, the less that we have to do later on. And you'll see in some of the cases that I share that we do really, really little kids. The disadvantages, I would say, for these particular appliances, they're limited. If I have a kid that comes in that's older, that has a lot of crowding, that has a lot of narrowing, I'm probably not going to recommend this for them. I'm going to use one of the other tools in my toolbox because I just know that this is going to be a little bit of a struggle. High vaulted palates, it can be challenging to wear the device. It's difficult for them if they have an oral restriction because they can't swallow very well with the appliance in, and they get frustrated. So sometimes I will tell parents, we can start working towards this and practicing it, but you may not find that they're very successful until we get their restriction addressed. That was true with my oldest. We started trying to do the Myo brace early on, and he really struggled to tolerate it until after his tie release. It does require parents to be involved. They have to reinforce, they have to be committed to the approach. They have to encourage the daily exercises and wear time. And it is very poor effectiveness unless you have that multidisciplinary approach. So if we're not doing muscle retraining, we're not going to get a major input, to the body to make change from just the device by itself. So we need to be doing these other aspects, body work, chiro, things like that as well. The next device we're going to kind of go over, which I covered last time quite a bit, was the Alpha Appliance. I really love the Alpha Appliance. It's very gentle. I actually have patients that I put in this just strictly for pain patterns and for cranial unwinding and osteopathic effect, not just expansion. And the advantages to it, it's very biocompatible. We have a couple different wires that we can use to make it with, one of which is nickel free, but it's a very flexible wire. There is an interior component, which I love because I really don't care for fixed expanders that only have that posterior sagittal effect. I like something that's going to keep my AP and maintain that. It's typically pretty kind to the tissues. It is great for sensory kids. I find that it's gentle enough that most of my sensory kids tolerate it really well. And it is positive tongue reinforcement. So that little loop that you see in the front there behind the front teeth is really helpful for attracting the tongue to the roof of the mouth and kind of starting to help develop that good tongue posture. So the design is great for that reason. There are some osteopathic effects. I do work with, and am fortunate to have a cranial osteopath in my area, and we see really great outcomes when we combine those therapies. And kids that are really young can use the appliance. So my 3-year-olds, the others might be bulky for them. This they seem to do really well with, and we get good results with. So we can start pretty young as long as they do the scan and tolerate the pictures. Then we give them the green light to move forward. Disadvantages are it definitely can seem a little slower, especially in older kids or kids that are really crowded. It does require some extensive provider training. The first several ALFs that I did, I really just felt like I wasn't getting anywhere. It wasn't doing what I wanted it to. I went to multiple courses. I actually gained a lot of benefit from just collaborating with other ALF providers and kind of saying, hey, this isn't working here. What are you doing in these cases? And that was extremely helpful for me. It requires patients and parents who are committed. They cannot just put that appliance in there and expect it to do the work. They've got to be doing lots of other things, myofunctional therapy, body work, chiropractic adjustments to really support the treatment. It is very ineffective if we aren't taking that multidisciplinary approach. It does require an increase for focus on hygiene. It requires regular adjustment appointments. It is a little more costly to fabricate and requires labs to have specific training to do that. And one disadvantage I will say is it can embed into the tissues. So that is something that if you've ever had to deal with an embedded appliance before as a provider, it's really important to do everything you can to make sure that your adjustments are proper and you're keeping a close eye on the patient. That is not fun to manage, and for parents, obviously, it's really, really stressful. So that's important. Let me just hop out of the full screen for a minute to see. It looked like we had a chat come up. What kind of outcomes have you
I'll
seen
go
with
over
that?
those at the
Okay,
end. I'll ask
perfect.
everything at the end. You don't have to worry about it.
Fantastic.
Keep going.
I was going to say, I can't get to them in here, so
Yes.
I have to hop out of it, but that's
I
great.
will manage that. That's perfect.
Beautiful. So the disadvantages of the ALF, as I mentioned, they're going to be very similar to the next one we discussed. This is our design. It's a little different again than the next one we're going to go into, but it has those positive reinforcements for the tongue to go to the roof of the mouth. I typically skip the U-shaped clasps in most of my patients. I may put little resin ledges to help the appliance retain there, but I do not find benefit in those U-shaped clasps most of the time. As we expand and shift, they sometimes just aren't in the right place and I end up taking them off. So that is one design. There are others for the ALF as well. This is a case of a really, really little girl. I think she was 3 when I started with her. And she was a very good compliant little patient. She got great movement and expansion. And we started having good spacing open up, and she's very close to, her upper jaw being caught up to her lower jaw. But you can see, even going just back to this initial photo, kind of the V shape to her palate, a little asymmetry even to her palate, and how significant her crossbite is there on that right side of hers. And we're improving that as well as getting all that nice spacing, and we've got a much, much more rounded arch form. So she's doing well, getting room for those permanent teeth to come in. And like I said, started really young and was a very compliant little gal. And then this is another patient I started with really, really young as well. She had a lot of crowding and tipping in of her teeth, a really high palate, and she was struggling with a lot of her speech sounds. She did have a tie release as well, so we did comprehensive care for her. She did myofunctional therapy, and she had a beautiful outcome. This is her and her ALF appliance. We did have to put some ledges to kind of open her bite a little bit, and she gradually got all those permanent teeth starting to come in. So she had a really nice overall outcome, and that was her after a year of treatment. So when we're younger, in my experience, in my hands, I see that the ALF seems to work better and more quickly if we're in a pretty good growing window. This is a good example of that U-shaped class I was talking about. You can see how far it is away from the canine on that side. Like I said, don't really care for those. I usually leave them off. The kids complain that they kind of irritate their gums. The adults complain of the same thing. So if I have an issue with retention there, I'll usually add one of those little resin ledges that you see the cool colors of. And the kids have fun picking their colors. This is a Crozat appliance. This is similar, I would say, in advantages to the ALF. You're going to have the interior component. It's adjustable. So a lot of times this mushroom loop, it's called in the front there, I may start without that and just use a basic Crozat design and go back and add that as the expansion continues. So I would say that is one of the benefits of the Crozat is I can solder, you do have to know how to solder, but you can alter it, you can add to it, you can do some things to help that Crozat, as development continues to change and accommodate molars and have distal extensions, there's a little more flexibility to the design. There is, I feel like a better effect for kids that are older. If I have a 7-year-old that has a lot of crowding, that needs a lot of movement, I'm probably going to choose the Crozat over the ALF just because I find that works better at that age sometimes. It does act as a retainer after, just like the ALF, so I appreciate that we don't have to make something totally new for the child to adjust to. They just start doing more nighttime wear, and it can be used in younger patients as well, and it's better as well for some of those deep bites because we can add the little ledges. I had one little girl who was really, really severe crossbite, and we just added resin to the cribs, and she wore that resin until we cleared the crossbite, and then we removed it, and we were able to keep going. So it is very flexible. Disadvantages are, again, it requires extensive provider training. You have to have patients and parents that are committed and compliant because they can remove it. It does require more focus on hygiene. They are at higher risk of getting cavities wearing this all the time. It does require regular adjustment appointments. You can't really do video check-ins, and they are costly and require some significant lab training to make. The repairs can be expensive. If they break the body wire, sometimes the appliance has to be completely remade, and it also can embed in the tissue. So similar to the ALF, this is a little guy who had bedwetting, very severe grinding. So you can see his poor little bottom teeth that are coming in there, the permanent ones, they are turned sideways and already don't have enough room, let alone room for the ones beside them. After we did treatment with him, he had tie releases, he had expansion, he did myofunctional therapy, and this was him older and adorable, and his bedwetting completely improved, and mom is over the moon excited about the outcome for him. So as he's starting to get his permanent teeth, we're monitoring him. He's in retention. Usually when they start losing the front teeth, we get into a holding pattern where we kind of have to pause anyways and let some things fall out and come in, and I put them into retention, and then we come back and revisit if we need to do a little more expansion. But all of that time, I'm typically able to use the same appliance. So that's an advantage to the Crozat, I would say. The BioBlock is a very different system, and I would say it definitely requires a lot of compliance. There are different versions of these, but they're usually still going to be in phases. I did Dr. Hang's class, and he has what's called his Hang expansor, and then his habit appliance, where he kind of has that lower jaw biting forward into what's similar to your later stage BioBlock. So you can get some areas of irritation on the floor of the mouth, getting the kids to wear it through that to be compliant, wearing it, keeping their teeth together as needed to make the change can just be a little challenging. I actually did this, actually the Hang version with my oldest, and you definitely have to be prepared for the drastic change that you will see. I have some concerns with these particular appliances about some of the cranial strains that can be created. My oldest does struggle with some headaches, and the BioBlock seemed to make it significantly worse for him. So I will say that if I have a patient that is sensitive in any way, I would not do this on them. And I really rarely find a lot of parents that I feel like are compliant enough to go through this type of treatment. It does require sometimes, at least the one when we did Hang's approach, we eat with it in. It's difficult, it's uncomfortable. Getting the kids to do that can be hard. It is a little unstable. That is actually why we were ultimately unsuccessful with his treatment, is he lost his appliance at school, and by the time that we ordered and replaced it and got his new one in, he had lost so much ground. Then these teeth became wiggly that we were holding on to, and we just weren't able to continue in the appliance without some major change. So I would say it can be really beneficial for cases that really need significant AP. As you will see, that anterior posterior dimension changes a lot, but you will have a very serious ugly duckling stage. So some parents are not going to be on board with that and will freak out. So it's really important to prepare them. It does require patients and parents who are committed, because it's not a comfortable appliance to wear. It's not comfortable to eat in, and it will make them. My son at the time, I believe, was right around 7, 8 years old, and he was very self-conscious about it. They do have to focus a lot on hygiene. He got a lot of plaque buildup. We had to be really judicious with our cleaning and brushing. And he had regular adjustment appointments, of course, that we had to stay on top of to make sure we were keeping the appliance fitting well, that we weren't unseating somewhere. At one point, it wasn't seating properly on a molar when he was putting it back in after meals, and it was causing tipping of that molar. So it requires a little more oversight. The repairs can cause significant interruption. Losing it can cause even more interruption, and it is very age limited. We really need the baby molars in place and the adult front teeth in place to be able to do this treatment. So that's a very short window of time. This was my oldest when he was going through his, and like I said, serious ugly duckling stage. This was actually not even as far into his treatment as we got. His front teeth became even more flared forward, which, as a dentist and permanent teeth, that was a little bit scary watching him go through that phase, because I was like, oh my gosh, I don't want to have any damage to these permanent teeth. But he was really, really self-conscious, was in school at the time. This was difficult for him from an aesthetic perspective. He got great, freeing up of that lower jaw. We addressed his tie eventually. We did a lot of things. I don't have his final pictures because, like I said, I didn't ever finish with him because we lost his second stage appliance and completely transitioned to a different treatment because this was just not possible to continue with once he lost those baby molars. So final thing that I was going to kind of cover as far as appliance types is the Vivos. And like I said, last time I was kind of just getting started in this, but now I have gotten quite a few more adult cases that I've treated. They have different appliance types depending on the severity of the apnea for the patient. I use the DNA for most patients, but the mRNA is great if you need support for nighttime and for airway. And I have seen really good results with both. It does work really well, I have found, and I will recommend this type of treatment typically for adults and teens who are not in an active growing phase. It is removable, so you get better compliance from adults than, maybe getting them to wear an owl for a crow's out all the time. It is FDA cleared for the treatment of sleep apnea. It can alter the AP, anterior posterior dimension, as well as sagittal, but depending on your design. And the bite can be established to allow for TMJ decompression. So like I mentioned, I'm in an appliance right now, and I have pretty significant damage to my joints. Primarily my left side is the worst. And I was able to talk a little funny, but have my bite supported a little bit in such a way that it actually relieves my TMJ discomfort and helps me and expand at the same time. So I think that's a great thing for patients who have other issues happening. I've been able to kind of combine some of my TMJ training with the Vivos appliance and getting a specific bite to support that joint. It is a little bulky. Of course, adult patients don't quickly and easily adapt to that, and they don't love it. It's very tricky if it breaks. I just had an adult patient, actually, their lower one broke, and we're having to send it off for repair. And that can interrupt treatment. And sometimes the fit can be poor. So that can be a challenge because they really just don't have something to wear inner rim. And most of the time we can repair them in office, but if it breaks in a specific way or spot, we can't. It does require patient compliance. It is going to have some negative impact on our tongue posture. So all that hard work your myofunctional therapy has, done to get your tongue up into the roof of your mouth and work really hard on your proper swallow, you have to learn around this appliance to do those things. And what I found was for some patients, they really had to go back to their myo afterwards and work hard on that. There is a lot of times a need for stage 2 treatment. So they're going to have spaces open up, sometimes in a good place, sometimes not in a great place. We're going to get movement, but that acrylic isn't bendable and flexible like I can do with a Crozat, so that it's sometimes easier to finish them out in like clear aligners or brackets and wires. It is expensive and it's very time consuming to submit the case. When it comes to Vivos, there's just a lot of baseline things you have to gather and be sure not to miss when doing those. So this is an adult case that I saw. She had had braces, as you can see by her lovely retainer there. And we are about done with her Vivos treatment. We're getting ready to go into clear aligners for her. And this is where she is now. And you can see, like I mentioned, those spaces that kind of open up, and her bite is open because of the acrylic between the teeth. But she's at a good point now where we can move her into clear aligners and tweak and modify. And I do typically leave that space behind the first or second premolars so that we maintain our airway and tongue space. And then we would correct, occlusion and alignment and all of that in that second phase. So she, as you can see, we don't have teeth tipping, which is what a lot of people will say about these types of expanders, Vivos, and other things. Oh, it's not true palatal development, it's tooth tipping. But you can really, really see from her initial photo here to now how much palatal change we've had, and her teeth are not, tipping out to the side or anything like that. So we are getting some good change. And she was a little more complex case because she has those tori on the bottom, those lingual tori. So in those cases, sometimes I will warn patients, especially on the roof of their mouth, that we may see some struggle with getting good movement and good expansion. So in my office, we do a comprehensive approach. It's good and bad to have all these tools in your toolbox because I know a lot of this stuff in my head and when I would use certain things in certain situations, but it can be a little overwhelming for staff. It can be a little overwhelming for patients. They might have had another child that we've treated and now we're treating this child differently. So, sometimes that can be hard for them to wrap their brain around, but we take time to explain why we're doing something different for this child versus another child. We always recommend bodywork support, osteopathic manipulation, if they're having inflammation, allergy testing, and things like that, myofunctional therapy, breathing re-education, and then appliance treatment and addressing the oral tides is a big part of our treatment plan. And we do laser biostimulation to help with recovery and to kind of ease them through the process as well. So lots of different things to think about, and certainly more tools that you can add to your toolbox. And I'm sure a lot of you who are experienced in these things, but that's just kind of what I found with my experience using all the different types.
Amazing. Thank you so much for sharing so many cases. We love seeing cases. It's so funny. So I just went to a dental CE meeting right here. Do you mind turning that off so we can see each other really big on the screen? Perfect. Awesome. So I just went to a dental CE event, and the girl who sat next to me graduated with me from dental hygiene in 2010, and I haven't really seen her since. And she's also doing myofunctional therapy somewhere else here in South Carolina. And her dentist does all these functional appliances. And we sat next to each other. And that's exactly the talk that we were having. Because of course, you guys know me, I had MARPE done. So I'm like always pushing for fast and get it done, And she was sharing with me the cases that her dentist has and how successful they have been. with some of the Vivos appliances and things like that. So I was like, I need to talk to her. I need to see these. And then you you shared so many with us today. So that's perfect. We do have some questions coming in, and if anybody listening wants to ask anything, please put in the chat box. What kind of outcomes have you seen with the ALF when a patient does not partake in osteopathy during treatment?
So I would say for a long time in our area, we didn't have an osteopath. I found other things that seem to be very effective for them. So I have some craniosacral therapists in my area. I have some chiropractors who have some advanced bodywork training. So I typically just tried to get them with a provider if osteopaths were not available, which, like I said, we just got ours in the area in the last 2 or 3 years. Prior to that, we had to make do with, other things. And if they are not doing the osteopathy, definitely we can see a slower movement in things. Kids that have more challenges, that have some of those strains already present, are not going to do as well. And also, I would say really the myofunctional therapy is the biggest piece of it. If they are not doing myofunctional therapy with the ALF, they're not going to move well. They're not going to retain well. They're not going to make good progress. If they aren't doing body work, that is something I see. It's more of a case by case basis. Sometimes they're doing okay. Other times, if they've already started off, sort of struggling in a more complex situation, we don't make as good progress. It just depends on the severity of the case to begin with.
Perfect. I recently saw an ALF provider recommend my functional therapy after the ALF was done. And I was like, no. You need to do that during. Yes, that is so important.
Yeah. I tell patients that all the time. I'm like, that is the cool thing about this. It doesn't delay any of our other stuff. We can do everything while we're in the ALF.
I have another good friend, also dental hygienist, that graduated with me. And her first daughter, she took to an incredible provider in Atlanta that I work with all the time, Dr. Samira Jafari. And she did orthotropics. And yes, you're absolutely right. Her teeth were all tilted out. She developed an open bite. And I'm looking at it, just holding myself in the chair. Oh my gosh, I hope this is good. She's my best friend. Oh my goodness. And this has been like a year now, and her smile is beautiful.
Yeah.
But I got so worried that she has more kids. And then for the other ones, they were a little bit more sensory. So I said, well, for those kids, I think that the ALF would be they'll handle it better. So she went and had the ALF done with both of them. And she's not happy. She was like, oh my gosh, I'm kicking myself in the butt that I should have done orthotropics for the other two also. However, I believe she has made the right decision. Not every appliance is going to be perfect for every child. But her question to me was, how often should they be adjusting the ALF appliance? Because she mentioned 1 month doesn't seem to be enough.
Yeah. The ALF is tricky because I feel like when I very first started using it, I was over adjusting it. So it's really tempting to want to do it more or to want to do a bigger adjustment. But my cases went better when I dialed it back and then combined it with those other therapies. So I would say when it comes to ALF, you have to be prepared to do other things. You have to be prepared to do myofunctional therapy. You have to be prepared to do tie releases. You have to be prepared to do body work. But if you go faster, all that's going to happen is the appliance is going to distort. The teeth are still going to be in the same position. The muscles are going to get overwhelmed, and you're just not going to get a better result. So slow and steady. And that's why I say the ALF is something that's going to go slower, and you have to be patient. And it's not for every kid, and it's definitely better when they're younger. And it is good for sensory kids. I have some autistic kids. There's no way that I could get them to do orthotropics at all. It wouldn't happen. It would be a failure. And they're not going to get as far with the ALF as they might with the Crozat. But I know that limitation for them, it's still better if we do the ALF than if we do nothing and be failing with the other appliances, so to speak.
What is the time that we should expect of treatment for a young child on an ALF versus an adult? Is it similar?
So I actually don't use ALF for expansion in adults.
Okay.
I tell my adult patients if we start with ALF in them, it is for cranial unwinding, it is
Mm-hmm.
for pain patterns, it is for tongue posture and reeducation. I typically do not use ALF for expansion. I use it to get the cranial system healthy and then I expand them. So
Mm,
it is more of a stabilizing device and an osteopathic device. And especially before we had our osteopath here, I used that kind of in place of the osteopath and had them doing body work. And then we went to do expansion. But for kids, if they start young, usually they're finished with the active expansion within about 12 months. So my 3, 4, 5 year olds, I will do expansion and adjustments on them for about 12 months and then they go into retention typically.
wow, that's incredible. Such valuable information. Another question was, do you use alpha in adults? If so, who's the best candidate for it? Or do you add the bead to your ALF design?
I have not used the bead a whole lot. I have had providers, friends of mine that have used it, and they've complained that it can be bulky and awkward, and obviously you can't take it off. So once it's there,
Mhm.
you either have to cut it off permanently or leave it alone. So I usually just have them use other things in addition to their ALF. If they're still really struggling with their tongue posture, if they're having a hard time with their swallow, then we add myo spots. We do something else to get the tongue up there that isn't permanent. And, like I said, for adult patients, I do not do typical expansion with the ALF. I do have some adults that come in. I'm, one of the only ALF providers in the tri-state area. So I have patients come in that say, I want an ALF. And I
Mhm.
just tell my adult patients, that's totally fine. We can absolutely do that. I just want to properly prepare your expectations that
Yes.
we are not going to get significant expansion for you with the ALF. The case I showed you on that adult patient that was a Vivos patient, we are only about 8 to 10 months into treatment with her in the Vivos. That would have taken maybe forever or not even happened with the ALF. We would not have been
Mhm.
able to get there. So in those cases, I'm usually going to recommend something like a Vivos appliance. And we can still go very slow. We don't rapidly expand. We're still going at a slow rate. And I tell patients, you know your body. You know
Mhm.
what you can tolerate. You know how you're feeling. If you feel like you're having a lot of discomfort after your adjustment and your body isn't adapting, then we're going to slow your adjustments down. And most of them kind of get to the point where they're comfortable at our routine twice a week. But if they're not, they're doing once, and that's perfectly fine. Or they may slow it down if they're not seeing their body worker, as regularly. So maybe they went on a vacation or a trip and they didn't get their appointments in
Mhm.
right before, and then they may adjust their expansion a little.
Can you please repeat the name of the front part of the crozet?
So there are two different types of wires you can put on the front. There are cat wires, which kind of look like the two that overlap,
Mhm.
and you can expand them or move them independently. I find that kids especially bend those and they get misshapen because they'll catch them on something or they poke them. They just don't respond as well to those. So I create a mushroom loop, which is all connected, that has the little loops there where you can expand it and make it push forward and develop that AP. And so the mushroom loop is typically what I use on most of my crozets.
Perfect. Um, how would you decide in these functional appliances with a patient versus something more aggressive? Who are the good candidates for these functional appliances?
Um, so the functional ones, I would say, I'm going to typically like my ALF, for example, young kids that maybe have sensory issues, autistic, I always tell parents my way of describing it as a parent, because I have one of each of these kids, is does your child get upset if their sock is crooked on their toe? Do they throw a
Oh,
huge fit if they put
every day with my 5-year-old.
those are kids that I tell parents, okay, now just be prepared. Like, I still think that we should maybe do this appliance with your child, but you're gonna have to stick to your guns for 1 week and say, we are not taking this out of your mouth. I will give you whatever arnica or Johnny Pops or whatever you want, but we are keeping it in for a week because that is my second child. He will scream bloody murder if his sleeve is twisted in his jacket until he gets it fixed. He cannot handle the feeling. And that was his reaction. I had him in a Crozat and he said, Mom, this is a torture device. Why am I wearing? I can't eat anything. And I was like, I understand. It's an adjustment. I can give you some arnica. If it's hurting, let's do some arnica. It's not hurting. It just feels weird. And I was like, okay, so I know that you're fine, but you don't like the feeling just like you don't like your sock cricket on your toe. It's not going to kill you. And by a weekend, he was sitting at the movie theater eating popcorn. And I said, I thought you couldn't eat with that. And he goes, oh, it's fine. I got used to it. So I was like, okay. But you got to have that parent that isn't going to freak out and be like, oh no, are they in pain? Is something
Yes.
wrong? Is because it is going to, for those kids, it's going to be very difficult to adjust to. So, certainly my really sensitive kids, I will choose ALF. If they have a deep bite, I don't do ALF. I'll typically do a basic Crozat design with no motion loop because they'll embed that ALF with clenching and grinding really easily. And those are not fun to remove.
Do you see any sleep apnea patients?
Mhm.
Have you seen any significant impact on their airway health and sleep?
Yes,
Can you share with us?
huge, huge, huge. We see a lot of improvement in bedwetting, honestly. Most of our kiddos within 4 months or so, that's gotten better. The older they are, the harder it is. If they're teenagers, I think that it's difficult because we have more hormonal things happening by then because the sleep has been poor for so long. But I usually have to coordinate with, a provider that supports the hormonal therapy and testing and things like that for older kids. We see tremendous improvement in bedwetting. I have had kids taken off the spectrum because they've made so much progress in their speech,
Wow.
in their, social interaction and everything. I have seen a lot of improvement in oxygen levels. Actually, my youngest was really sick earlier this year and got this terrible, we think it was Steven Johnson's, we're not really sure, but he had oral ulcers in
Wow.
his body, ulcers in his eyes, they were everywhere, and his tongue posture was awful. He was grinding his teeth. His tongue, I think he just didn't want to touch anything with it because it was so painful.
Yeah.
And I didn't want to put anything in his mouth because I knew how painful it would be for him.
Yes.
So once he was relatively healed, to try to work on our tongue posture again, I just had him sleep in a myo brace. And I tested him with the sleep image ring and just putting the myo brace in. We did nothing else. It was literally one night with the sleep image ring, no myo brace. He had 6 to 7 apneas per hour. That's how bad it had gotten. And then putting the myo brace in for sleep the next night, sleep tested again, he had 2. So
Wow.
just the addition of that made such a huge difference for him through that recovery period. And I did 2 nights and they were relatively similar. It was like 6 apneas and then 7 apneas the other night. And the next 2 nights it was 2 and 3 as far as with the myo
That's
brace in.
incredible. How
So yeah,
how young can you use the sleep image rings?
we use it on 3-year-olds.
Amazing.
Yeah, parents that if they say they won't tolerate it, I tell them it's a spy ring. And if
Uh-huh.
they haven't seen Spy Kids, they have to go watch the movie and that they have to wear the spy ring to bed. So we kind of make it fun for them. And then I tell the parents, if they still are really resistant, let them fall asleep, sneak in, put it on their finger. I show them how to tape the 2 fingers together and they do really well with it usually. We have them do 2 nights always.
Amazing. That's such a big, important step because
Hmm.
we can't really see much in one night.
Yeah.
What are common challenges or complications with expansion appliances, and how do you address them?
I would say the biggest challenge is getting them to keep their fingers out of their mouth and leave the appliance alone. with ALF and Crozat, you can take them out. So you have to have, like I said, parents got to be on your side. You got to prepare them. Hey, they're going to want to pop it out. And most of the parents are really good. I have a couple little kiddos right now that they're like, I don't touch it, mom. And you watch them flick it out with their tongue and you're like, ah. So that's a little bit of a challenge because you have to walk that line between, like telling the parent that their child is creating the issue and, getting them on board with helping support. But most of the time we get good support from parents. And then I would say the other issue is just usually, if you are not keeping an eye on it, and if you have a patient who really clenches, that wire can go down into that tissue so fast and the tissue grows over it. And luckily I have a laser, or else I would not really want to take those out very often. But I don't have to do it a lot. But there was a case, probably my first one in 6 or 8 months, that the other day the girls were like, we need you right now. And I went over and I was like, oh my goodness. And the ALF was just buried in the tissue. And it was weird because it was a little girl that we've seen for over a year. She's about ready to go into retention. We've never had this issue before, but she just embedded it, and I had to numb her up a little bit with some topical and get it out with the laser, and she was a champ about it. But that can be very stressful for the parent, for the provider, for the child. So I would say that complication is probably my least favorite.
How can they prevent that? Or
You
can
put buttons, those
that's what you
acrylic on
mentioned.
the teeth.
Okay.
You can design the appliance differently. So if that happened, I might consider, ordering a Crozat or something that doesn't go in that area. Because she was really at the end of treatment, we started having her take it out during the day and wear it at nighttime for her retention.
Okay. Very good. In your experience, you mentioned a little bit about moms and parents having to be on board. How does family lifestyle and patient compliance influence the outcome of expansion appliance therapy?
I would say it's really very dependent on the parents believing in the treatment. If they believe in the treatment and they understand the benefits to their child, you can get really good parent support. If you have mom on board and she's really happy and excited and wants to do this, and maybe it's a divorce relationship and dad is very opposed to the treatment, then it can be a big mess. And so I find that it is important to have support from both parents. And we've seen, households in all different scenarios. We have some kids that, mom is working and she doesn't really come with them. Either dad brings them or the nanny brings them. And, working through that other person can be challenging sometimes because information doesn't make it back sometimes to mom or to the person that's enforcing it on the weekends or in the evenings. So I think it is important to really have a good family dynamic to where even if they maybe aren't 100% on board, they are going to support the decision that's made to stick with it. I have very, very few families that I have to terminate treatment with. But usually in the first 30 days, I will make that call if they are just not leaving the appliance in, if they are coming in for multiple visits because of complaints of discomfort, things like that, then I just kind of have a talk with the mom and say, I don't think this is the right fit for your child. We have a clause in our treatment plan that states, if we embark on treatment, which you have to pass our red light, green light test, which is scanning, doing expansion photos. So they have to tolerate, the retractors and all those things and the mirror. And if they can't get through those, then we say, this isn't the best stage. Let's revisit in 4 to 6 months. Or maybe we put you on a myobrace program or do something to start helping habits with myofunctional therapy. And then we revisit. If they tolerate that, then we get into treatment and mom just continually, oh, they're having a hard time. They took it out at school, or hey, they've got it out. We can't get it back in. Then we have a clause in our contract that just says, you will have a cost, that will cover our hard costs because we've already ordered the appliance. It's already been, delivered. We can't really do anything about that cost at this point. That part has to be covered, but we'll terminate all ongoing charge for the case and decide if this is the right fit, because I don't really want to be wrestling with that. They don't really want to be wrestling with that. I really don't want to do it if it's not going to benefit them. There's just
Mm-hmm.
no, benefit to either side of that situation.
I agree. What recent advances in expansion appliance technology or techniques do you find most promising?
Um, I'm really excited. We've started using red light therapy. So we have a summous laser, and there is a specific setting that we use that treats the palate and then
Mhm.
up and down the roots of each tooth. So I'm really
Mm.
curious to see how that starts impacting our movement because I have a case that is an ALF case on an older kid that I inherited from another doctor. They moved here and I took over their treatment,
Mhm.
and he's 14, I think. So not a case that I would have typically done ALF
Mhm.
for. And there's an area, a couple of them actually, that are just not moving. They're, the appliance is being adjusted and they are not budging. And mom does body work. She's working on kind of some of the areas of, a concern and tension within the cranium. So I know he's getting that support. But last time I was like, let's just add red light therapy. Let's see what that does to his movement. Maybe giving that input to the system will overcome this obstacle. So I'm really curious to see, because I feel like we've done, as time has gone on, just my skills in adjusting the appliance,
Yes.
our timing of releases and seeing myofunctional therapy has sped up the cases. Sometimes I was doing a case for 2 or 3 years and neither one of us liked it, us or the patient. And now most of our cases we finish in 12 months. And I think
Mhm.
all those micro changes we've made along the way have helped us get there. But I'm really curious to see how the laser helps.
That sounds amazing. Do you usually uh, recommend a release before expansion or after?
It depends on their intermolar measurement.
Okay.
So I make that decision on a case by case basis. If I have a 5-year-old who comes in who has clenching and grinding and they are at 34 millimeters intermolar, I might go ahead and say, let's get going on myo and let's get releases as soon as you're muscularly ready. And then we'll be doing expansion as well. But if I have a little one who comes in at 5 years old and is 29 millimeters intermolar, I'm usually not going to start even considering their tie release until they're at least about 4 months into expansion.
Okay, very good. I know that people are going to ask us what brand red light? Is it a handheld device? What does it look like?
So yeah, I have the Summit red light laser. It's a therapy laser. It's kind of on the pricey side,
Mhm.
but it is one of the leading therapy lasers for all different applications. We have a well spa as well. That's kind of our next door neighbor to the practice. It's an extension of the practice, and in the well spa, my husband, who does personal training and things like that, he does treatments on like shoulders and knees. And
Mhm.
so it's the Horizon Summit laser. It will treat for all different medical needs as well as dental. You can get it with just dental protocols and with just medical protocols, but I actually use it for all tie releases. We use it pre and post tie release, and I've seen a huge difference for infants in their fussy window, in their
Yeah.
function. And we've probably been using it for 2 years now,
Oh, that's
with high
amazing.
releases.
That's
Yeah.
incredible. I have a red light panel in my house. I just went crazy and bought a big one. But
Yeah.
just for, my kids also in personal, but I am a huge proponent of red light therapy. I just saw that we had a question over here. I did not ask. What precautions are taken when there is hypermobility?
Um, so I really don't have a lot of those cases. I have had some cases where we have severe recession. In those cases, actually, there's one, I should have put it in here, that was a Vivos case, an adult male in his late 30s who had, I think it was 4 millimeters of recession on his canines, his lower canines. And so we talked about that at the beginning of treatment. We discussed the risks to him. He had severe sleep apnea, so he was really willing to do anything to make that better. And I did Vivos treatment for him. His palate developed beautifully in 10 months, and his sleep apnea improved tremendously in 10 months. And he had no change in recession on his lower canines. So we just went really slowly. We kind of listened to the body. We did discuss the risks of, the chance of creating additional recession or mobility on those teeth. But we also have a pretty intense hygiene program on our holistic and biological side. So if they have any mobility issues, any inflammation, any gum concerns, I'm going to have them treated for that with our ozone therapies and our laser and things like that before we start treatment. So I really don't have cases that I'm treating that are mobile.
Okay, perfect. Thank you so much. For everybody to know, Foundations of Orofacial Myofunctional Therapy 3.0, our third cohort, starts January 1st. So registrations are open. If you're listening to this in January, give me a call. We still might have a little bit of time for you to join us. And MyoCircle waitlist is open. It starts August 1st of 2026. I know it's long ways away, but that is a very seeked out course. Everybody wants to take MyoCircle. It's our advanced myofunctional therapy course, the why behind the exercises. So reach out to me if you're interested in taking that. Make sure you guys are in our directory. We have over 3,000 visits to the directory a month. Patients are trying to find you. Next week, I'm not going to say that because it's going to be January and it's not going to matter. However, we will see you guys soon. Thank you so much for always being here, for supporting these webinars that we do in Airway Circle. Thank you for everyone who joined live. Dr. Prather, you're always such amazing to listen and to learn from you. So thank you for sharing so much with us.
Happy to help.
All right. Thank you, everybody.